Happy Friday, everyone! My name is Noelle Schenk, and today I'm going to be talking about shared psychotic disorder in children and adolescents. So here's a brief overview on what I'll be discussing with you all today. So first, I'll touch on the key terms in the description of shared psychotic disorder, then I'll dive into the history of it, then I will discuss shared psychotic disorder and how it presents in children and adolescents, and then I'll discuss the treatments used for adults and then for children. So shared psychotic disorder, also known by the name folie à deux, is a rare disorder that is classified in the DSM-5 under the section on other specified schizophrenia spectrum and other psychotic disorders, and it is defined as a rare disorder that is characterized by sharing a delusion among two or more people in a close, intimate relationship. These relationships can be between romantic partners, which is the most common, but can also be between more than two individuals in a close larger group, which is sometimes seen in cults, and even families, which is called folie à famille. In these relationships, there are two types of individuals seen, the inducer or primary individual in the relationship, and the inducted person, or the secondary individuals in the relationship. The inducer is the individual in the relationship who has a psychotic disorder with delusions, who influences the other person or people. The induced person is a non-psychotic individual who develops delusions based on the influence of the inducer. This person tends to share in the same delusions as their inducer and, in some cases, develop other psychotic symptoms such as hallucinations. The first reported case of shared psychotic disorder was reported in 1860 by Jules Balaguer, who termed it folie communiquée, or communicated psychosis. In 1877, the term folie à deux was first coined. In the 1940s, Gralnick defined four different types of this disorder: folie imposée, folie simultanée, folie communiquée, and folie induite. Folie imposée, also known as impulse psychosis, described the delusions of one individual with psychosis transferring onto individuals without psychosis in an intimate relationship. When the couples are separated, however, the individual originally without psychosis loses their delusions. Folie simultanée, or simultaneous psychosis, is when both partners in a relationship share the psychosis simultaneously. Typically, both individuals have risk factors that predispose them to developing this condition. Folie induite, or induced psychosis, is when new delusions are assumed by an individual with psychosis who is being influenced by another individual with psychosis. And folie communiquée, or communicated psychosis, is similar to folie imposée. However, the delusions are presented in the induced partner or partners, occurs after a long period of resistance, and typically this induced partner will maintain the delusions even after separation from the inducer. Shared psychotic disorder was first listed in the DSM-3 as a shared paranoia disorder, but in the DSM-4 it was changed to shared psychotic disorder. Bigo et al. Analyzed shared psychotic disorder in children and adolescents under 18 in their study. They identified 48 children to have SPD, which included 42 induced individuals and 6 inducers, with parent-child relationships being the most frequent relationship when the induced individual is the child. Some associated risk factors for children to develop SPD are the presence of a dominant family member within the stable family, dependent and ambivalent familiar relationships, frequent family crises, domestic active violence or underlying threat of violent behavior, and social isolation. Typically, the inducer has a more frequent history of mental health disorders themselves and psychotic symptoms in the past. Also, they tend to be middle-aged women, such as the child's mother or female guardian. All of the subjects studied presented with delusional beliefs, and 32 of the individuals presented with hallucinations without differences between the inducers and the induced. Most of the children involved also presented with social isolation and safeguard concerns, which is a fear of being hurt or harmed. 77% of young people were also subject to adverse social circumstances such as poverty, immigration, and isolation. In terms of treatment, typically with adult patients, the inducer, aka the person with the original psychotic symptoms, is typically treated with antipsychotic medication and psychotherapy if needed, while the induced person or persons is treated typically with physical separation from the inducer and psychotherapy if further support is needed. In children, however, the treatment for the induced person is different. Physical separation from the inducer, which keep in mind typically is their parent, is ineffective and can be even traumatic for the child. In this study, there was only one case of spontaneous recovery of the induced when separated from their inducer. So instead, psychological separation strategies are used as the treatment. Psychological separation strategies promote independence of the induced person so that they can start to separate themselves from their inducer naturally with less traumatic impacts. Psychotherapy is also used as a treatment for induced children. Antipsychotic medications are not typically given to induced children unless their case is deemed too severe for purely therapy treatments. But with a combination of psychological separation strategies and psychotherapy, recovery from the disorder is possible in these children. Here are the resources I used in this presentation. Thank you for watching. I hope you have a great fall break.